Hello, and welcome to this Practicing Clinicians Exchange podcast series on multiple sclerosis. This is the second of 3 podcasts. Today, we'll look at current data supporting the use of many available disease-modifying therapies for MS. My name is Allison Boyd, and I'm a physician assistant specializing in MS at Sentara Neurology in Virginia Beach.
And hi, Allison. I'm Dr. Stephen Krieger, professor of neurology at the Icahn School of Medicine at Mount Sinai in New York.
This program is supported by an educational grant from Genentech. Partners for Advancing Clinical Education is providing this activity for 0.25 ANCC and AAPA credits, with 0.25 pharmacy credits available for nurse practitioners. To receive your credit for this program, please go to pce.is/ms. I'll repeat this link at the end of the discussion as well. Our learning objective for this podcast is to help clinicians develop evidence-based, individualized treatment strategies for patients with MS. We'll share some practical strategies you can apply in your everyday work as a key part of the clinical care team. Dr. Krieger, we've seen a very rapid increase in the types of MS therapies available in just the past few years. How has this affected the way you work with your patients?
Well, it's definitely increased the optimism of my message to newly diagnosed MS patients about how many options they have to treat the condition and how we can try to tailor our choices to their lives and preference. But it makes the conversation harder in a sense because we have so many more things to choose from, and gone are the days when you can just give patients a list of medicines or a stack of DVDs, you remember DVDs, with information on them, and have the patient go home and choose. Now with 20 or so medicines, that would not be fair, and it would not be really leveraging our expertise to help guide them. So I think what has changed is the optimism and the amount of direction that we as the care providers need to bring to that conversation to help to guide people to choices that they can reasonably choose amongst. That's sort of where I would start. How about you? How do you talk to your patients about disease-modifying therapy options and consider, not just the medicines, but also the mental state of the person in that moment? How do you meet them where they are to help make good decisions?
Correct. This can be very difficult and can be overwhelming for both me as the provider and the patient. I often may split this up into a couple of visits just because the person is coming in having been slammed with this huge diagnosis and their head is kind of spinning. And so we know that in any good medical visit, patients only absorb a small amount of what we're saying anyway. And I would say after a lot of the initial you have MS, a lot of people aren't hearing much else. So I try to first educate them about what the condition is, and then that helps to lead to why are we treating it and why are we maybe being so aggressive, and because a lot of these medications sound very scary. I may have to have a discussion with a patient that they're going to have to give themselves injections, or they'll have to go to an infusion center for an entire day and get it infused with bags of medication. And that can be so overwhelming, and patients think, well, why are you putting this all in me? So it helps to understand our goals of treatment, and then really trying to narrow down our very long list of the medications available to, I'll walk in a room knowing a patient's medical history. So some of the medications may automatically be crossed off the list just by knowing other comorbidities that patients have that would put them at great risk on certain DMTs. Also knowing the patients, getting a sense for them, knowing their lifestyles, knowing that if they're in a special, more high-risk population based on ethnicity or sex, it will really help to guide my presentation of which treatments I would like them to consider. I also will have patients do some research on their own, and I often use the pros and cons list. And I will have patients, I tell them, take one medication at a time, because if you do them all at once, you're going to be way overwhelmed, and make a pros and cons list for each one. And they may come across one and automatically throw it away and say, absolutely not, no way ever. But then they might come up with some really good questions and narrow it down for themselves. And then we can come to a decision together for what we feel is going to be the best, most effective therapy for them at that time.
That's perfect. And I mean, I think you kind of led right to this shared decision-making idea. How are you guiding them? How are you empowering them to learn things? And then they come to the table prepared to share in that decision with you. And I smiled when you said, they may come across something which is a deal breaker because, when I talk to patients about, let's say, the different routes of administration, I might say the words, this medicine is an injection. And you just see the look on their face of horror at the idea that that's something they'd have to do. And you immediately know as a clinician, okay, this isn't the path that we're likely to go down. And it helps you. I think the most important piece of shared decision-making is paying really close attention to how the patient is responding and to what they expressly care about. So you mentioned how you narrow down some of the choices. In my practice, I never really talk about more than, let's say, 4 medicines at a time with a person. Either they narrow it down, I narrow it down, and then we've got 3 or 4 left that we then flesh out in some more detail. Can you talk a little bit about some of the factors that influence your decisions in terms of how you narrow this down, either the clinical evidence, efficacy, safety, context?
I think all of the above. Definitely think about safety because for patients, they don't want and I don't want a treatment that's going to be worse than the condition. That never is a good situation. Also, just the lifestyle. I used to be able to tell patients that we never had to worry about insurance coverage because all the medications were brand name and all the companies were great about patient assistance. And I think that speaks well to the companies recognize these patients need these medicines. Now that the scope of insurance and payers have changed, that's a little bit different of a conversation. So we may have to consider some of the copays and transportation. If patients have to go to an infusion center, but they don't drive, transportation is definitely an issue. And just the many, many social factors of being on a medicine. We constantly review the goals of treatment because somebody may be on a medicine for 10 years and completely forget why they were taking it or what our outcomes were. And when I can tell them, well, you're still stable, that was our goal. Or versus a patient whose expectation of a medication may be that they're going to feel better and everything they're experiencing is going to go away. I think these are all ongoing conversations. And we know that over time we may need to change their treatment. So just keeping all of that in mind and an open line of communication with patients is the most important because I want them to feel like they can come to me with questions or any concerns, any side effects, and that we have educated them on what to expect and that we're there for them. How do you talk to your patients about the goals of disease-modifying therapy for MS?
Yeah, as you said, those goals might change over the course of someone's life and even their disease history. It is important, as you said, to make it clear that our goals are preventative and that none of our disease-modifying therapies necessarily make someone feel better, but rather, I've used the phrase, we kind of freeze the disease at a certain point in time to prevent it from doing anything else. Preventing relapses, preventing new lesions, preventing disability over time. Maximizing brain reserve is a phrase I use a lot. Anyone who knows me or my work will know that you can't give me a microphone without my talking about fostering reserve and filling the tank of reserve, which is the metaphor that I use with my patients. I've called it the topographical model of MS. It's a notion that we try to keep the disease underwater, submerged by our nervous system's ability to compensate. But that none of our medicines are perfect at doing this. And these medicines are one part of the strategy. And another part is all the things that they can do to manage their comorbidities, optimize brain health. And this is where a lot of factors in long-term management come into play. That notion that none of our medicines are perfect, that I really think is important to set achievable goals and manage expectations. So we may start someone on a medicine and do an MRI scan every year. And obviously the goal is no evidence of disease activity, nothing new at all. We can't always achieve that perfectly. And so I try to set expectations even around each MRI scan. What will we do if there's no new lesions? Well, we'll celebrate that. What will we do if there's one new lesion? We might tolerate that. What will we do if there's 2, 3, 4, 5 new lesions? We will act on that. And that way, the patient isn't freaked out when he gets the MRI report before I have a chance to talk to him about it, or maybe he still is freaked out, but at least there'll be a plan and an action plan in place. That's sort of how I talk about goals and manage expectations. In my own practice, I don't get into how the DMTs, the disease modifying therapies, work in great detail. I mean, unless somebody really wants to know. I wonder if you do it the same way. I mean, do you get into mechanism of medicine? Do you talk about how these medicines are suppressing or modulating the immune system, or do you kind of do you skip those sorts of details with your patients, Allison?
I tend not to get into too detailed of the science of it. There are a couple that are just easier to explain in very simple terms of how they work, especially for some of our, one of our newer medications. That's a completely different process, more of an induction reboot therapy versus consistently taking it. So there are some that I will do a little bit more in depth. But most of the time, I really look at the big goals. I explain to patients that there may be times that we do change their medications, but to ultimately think of them as long-term. Because I think one of the things I've struggled with is that patients now see all of these options and kind of think we can change quickly. So they'll make a decision initially thinking, this is what I want, and they take it for a couple of weeks and they're like, oh no, this is not what I want. So at that point, really having the expectation that these are long-term, but that we can change if absolutely needed. The goals of treatment, definitely always reiterating, reviewing that at the office visits. The more we educate patients of what to expect with the medications. So, and being honest with that, what's required for lab monitoring, for possible side effects, and all of these different things that really go into taking the medications. I think it's important that we continue to discuss with our patients at every visit and not just assume that they remember from the last visit. There's always new things coming up. In my experience, my MS patients are very well educated, which is, I think, absolute wonderful thing. And I always encourage patients to get more education because it is more empowering for them and they have, more of a control of the condition versus the other way around. However, some of the new therapies sometimes can become overwhelming and patients may question, is newer always better? How are you, Dr. Krieger? What's new or different about the current treatments compared to older therapies, and where are you implementing or discussing these?
Newer isn't necessarily always better, but we do have sort of version 2 and version 3 of a lot of our medicines now, which have refined them a bit in terms of some of our oldest medicines. Glycerin or acetate, which has been out now for 20 years, has a generic available, which sometimes has made it easier from a financial perspective. We talked a little bit about that issue before. There are newer versions of older oral medicines. So we had fingolimod for over a dozen years now, and now there are second generations of that. Siponimod, which was studied in secondary progressive MS, ozanimod and ponesimod, which have been studied in relapsing MS, and both of those are in some ways simpler to start than fingolimod was, and certainly also very well tolerated. We've had oral fumarates for about 10 years now with dimethyl fumarate. Now in the modern era, there's diroximel fumarate, which is perhaps a bit better tolerated from a gastrointestinal perspective. There's also monomethyl fumarate, which avoids some of the metabolites. So you see the theme here that we're getting more and more refined versions of older medicines, even kind of a newer class of medicines, the anti-CD20 drugs. We've had ocrelizumab given twice a year by infusion for the last few years. Now there's a second generation of that, which is ofatumumab, which is given by monthly self-injection, others in the pipeline. And we can't even talk about all the possibilities. There's other orals like teriflunomide and cladribine. So you see even right here, just talking about the newer ones, we have to constrain the conversation on a per patient basis since there's no one size fits all therapy. But I think that providers should be familiar with at least one of each class of medicine so that they have one that they really know its mechanism, they know its tolerability, they use it in their patients. And if you know, in some detail, one in each class, that's still half a dozen or more MS therapies, certainly enough to be able to personalize that decision.
Yes. Well, Dr. Krieger, it looks like we're about out of time. To wrap up, let me ask you what you think are the most important messages our listeners should take away from our discussion today.
I would say optimism, personalization of treatment choices, and the availability of a great deal of good information about medicines that you can guide your patients to. And being familiar with one medicine in each class, I think will empower you as a clinician to help guide that conversation.
Thank you. I think those are wonderful pearls to take home. Thank you for joining me and for sharing your expertise, Dr. Krieger. We'll continue in the final podcast in this series, which will address strategies for improving long-term management. And thanks to everyone for listening. To claim your credit for participating in this activity, please go to pce.is/MS and complete the post test. Again, that is pce.is/MS. Thank you very much.